delighted to be talking to you. My name is Allan Frankel. I'm an anesthesiologist by background, but I've also spent almost the last 30 years thinking about how to achieve safe and reliable healthcare and the kinds of cultures that help to achieve safe and reliable operational excellence. To tell you a little bit about myself, I am the CEO of a company called Safe and Reliable Care. And by disclosure, so that folks know, we are a design group focused on achieving zero preventable harm and joy in work through the application of high reliable principles, the intelligent use of surveys, the application of electronic management systems, and coaching and training of leaders and teams. I might add that in the world of surveys, we have surveyed thousands of hospitals and health systems throughout England, Ireland, Wales, the United Kingdom and whole, Canada, America, heading into Europe, and also out into Australia and the Far East. So we spent a lot of time thinking about what culturally predisposes to operational excellence. Let me spend a few minutes thinking about this with you, because in order to look at the culture of an organization, you do culture surveys, you do an analysis, interviews and so forth, and you evaluate how people are doing and how the work is unfolding and the levels of work-life balance and joy in work. It's extremely important when you look at that information to evaluate it against an ideal in order to understand the current state relative to that future or ideal state that you'd like to achieve. So one of the things we tell organizations all the time is that when they are thinking about culture, it's extremely important that they have this kind of ideal in mind in order to really contextualize what they're learning and then be able to act on it. So let me tell you a little bit about the framework for high reliability we use, and that we're just in the process of writing a white paper for, because it builds on frameworks that have been generated, many in the United States by the Joint Commission and other groups. Certainly the grandfather of patient safety, Lucian Leap, helped create one within the US, the National Patient Safety Foundation, and I've certainly seen some published in the NHS. But let's take a minute and talk a little bit about this one here, because it begins to explain when we look at culture, what it is we're looking for. So when healthcare leaders come to me and they ask, how do you achieve safe and reliable operational excellence? What I describe to them is that from an engineering perspective, I think of their organizations, your organizations, as culturally distinct work settings that have names, the operating room, Dr. Jones's office practice, central sterilization. Each of those, and obviously very different, an operating room, an ICU, an office practice where equipment gets sterilized. But nevertheless, you have groups of people who identify themselves as working in those locations. And they'll tell you, like I would, I'm an anesthesiologist and I work in the operating room, or I work in the intensive care unit. Those work settings have what are essentially organ systems and organs, just like a human being has organ systems and organs, cardiovascular, neuromuscular, lungs, heart. And for a human being to be healthy, all of those organs have to be healthy. And in the same way, for the operating room or central sterilization to be most effective and to function optimally, all of their organs have to be healthy too. We describe the four major organ systems, as you see in the center here: culture, knowledge, learning, which I'll get to momentarily, and leadership, are the four component pieces that have to be robust for the operating room to deliver effective surgeries, for Dr. Jones's office practice to effectively see and evaluate and treat patients, and for central sterilization to clean equipment and get it back up to the operating rooms for use during the surgical procedures. Now, these work settings, as they work these cultural components, as organizations think about them, the purpose for creating excellence across all of them is twofold. Obviously, the output that influences the care of patients and patients' families is what everyone thinks of as the Holy Grail, and I agree. But the truth is, it's people delivering that care that determine its excellence. And so the framework has to focus on those people, the carers, in the same way that it focuses on the patients and families. And when you achieve safe and reliable operational excellence, it's in service of those giving the care and those receiving the care. Reminding everyone that every one of us who delivers care will also ultimately be the recipients of care through some healthcare system somewhere in the future. So when we think about these four groupings or organ systems, what are the ways in which we characterize them? Well, let me just start on the top right. The cultural base, when we talk about personal accountability, we're talking about individuals' responsibilities to be professional, to engage in respectful interactions with others, because as Joe Shapiro from the Brigham and Women's Hospital in Boston has often said, while there might be a hierarchy of responsibility in healthcare, there is never a hierarchy of respect. So personal accountability speaks to professionalism, respect, and courage, because you have to have courage to engage with the organization and with all of the attributes that you see in this framework in order to be successful. Those personal characteristics then manifest themselves in the teamwork and collaborative efforts that make up a group's activities. And the teamwork activities we all know of as the briefing where you're planning forward and the debriefing where you're reflecting back, and then the mechanisms by which you communicate clearly in between. Individuals who are courageous, respectful, professional, participating in teamwork behaviors have to be surrounded by a healthy environment, which means, one, that the organization has to create a just culture where people can say, I am accountable for my actions, but I won't be held accountable for flaws in the system. And then the other aspect of a healthy environment that we've come to understand is critical is that people have to have the sense, the people working in a work setting have to have the sense that the people around them care about them, and in so doing, create a healthy community. So individuals with professionalism, respect, courage, participating in team behaviors like briefings and debriefings, where they feel that they're in a community that cares about them and an organization that won't unjustly hold them to account for things beyond their control, also have to have a mechanism for managing disagreements or tension or conflicts, because healthcare is complicated and disagreements arise. So how you come to a collaborative agreement as opposed to a competitive or accommodating or avoiding disagreements altogether is an important piece of this cultural base. And it requires the ability to distinguish between comments that people make that are positional comments from their underlying interests. The surgeon who walks in and says, I need to do my case early this evening. Well, their underlying interest can be the patient's exceptionally ill, or they want to get out of the hospital in time to see their child participate in some kind of recital. Well, both important, but obviously one is slightly more important than the other. And the positional statement, I need to do my case early, doesn't explain to you the underlying interest. So with that cultural base, you then need an organization where information is collected and transparently shown to people. And the information that you're looking for are the cultural, operational, and clinical defects that occur on a regular basis in the work settings in order to be able to look at them and make them better. And notice, I didn't talk about the clinical activities, making sure we deliver on the right protocol, or the operational activities, making sure the blood pressure cuffs work in the examining rooms. I'm also talking about the cultural aspect of things, which has to do how did the team work together? Did everyone know the game plan when the briefing was finished? Did people communicate clearly during the time that they were working together? Those are pieces of data that you have to collect that then become valuable to plug into the learning system. Well, what's a learning system? In this particular case, we're not talking about research or education as learning, although obviously those are key in healthcare. But in this particular case, we're talking about the capacity to self-reflect as a work setting and look at the cultural, clinical, and operational defects that are getting in the way of delivering the care that you want. That's the learning that we're referring to. And the application of improvement to those insights then allows you to continually improve the environment. There's a testing process, PDSA cycles and so forth, and in Lean, the Kaizens that help you understand what's feasible to change, at which point you then implement it to make it permanent and ideally make the system more robust and more effective. This culture, knowledge, and self-reflecting environments have to be run by leaders and managers. The middle management structure in hospitals plus the senior leadership have a responsibility to make this process robust, to make this gear turn. And leaders have three responsibilities, leaders and managers. They have skills that they have to learn, they have activities they have to participate in, and they have to manifest certain behaviors. So when we look at what those are, what we see is that, and let me just turn to the slide. We see that what they look like is this. The skills that leaders and managers have to learn about are issues of just culture. How do you ensure that you hold people to account for their actions but don't hold them for system flaws? Human factors. What does it mean to standardize and simplify a process to a forcing functions, for example? Improvement methodologies. How do you state an aim? How do you run an improvement cycle where you're doing plan, do, study, act processes? How do you use communication as a mechanism, as a dialogue that's bidirectional, where you're learning, where you have the ability to use appreciative inquiry and to hear what people say effectively? What do the team behaviors look like? Briefings and debriefings. How do you understand complexity science to understand how groups of people tend to deviate from norms of behavior over time and create increased risk, the same way we drive too fast or above the speed limit on highways? Those are skills that managers and leaders have to learn and then apply them in specific activities where they basically show up: rounds, briefs, huddles, safety forum, bidirectional dialogue in meetings and so forth, actively participating in the testing process that goes on in the work setting, being present in these activities. And lastly, when present with the knowledge in hand, and now you're there doing these things, what are the behaviors? Curious, humble, committed, courageous. You show non-negotiable respect, inclusive of everyone, hold people in high regard. Those are the characteristics of the best of the best leaders. And it's to this that our cultural surveys look to explain and describe the current state relative to the ideal state, as I've just described it. Culture can be measured and looked at, but only in the context of where you want to go. Well, so with that in mind, what are the kinds of cultural domains we look at? Learning environment, in other words, improvement readiness, local leadership and management. To what degree do they manifest the behaviors that we just described? To what degree do they give feedback to the people who report to them in such a way that those individuals feel supported? Can you see the teamwork behaviors and the safety behaviors in terms of speaking up about concerns? Are people comfortable performing those and participating in those activities? 2021, and after the COVID impact on healthcare, what we also know is that resilience and burnout, which are two sides of one coin, are exceptionally important. So what are the levels of frustration, emotional exhaustion, cynicism and leading to a sense of inefficacy and effectiveness, and then ultimately the worst of burnout, depersonalization. Do people feel that way? Do they perceive that in others? On the other side of that coin are these environments where people feel that they thrive, that what they're doing on a day-to-day basis is important and makes a difference, and emotional recovery when things go wrong, that they feel that they can recover quickly. And do they have some level of work-life balance? They go home at the time they say they're going home so that they don't have to delay plans that they've made with their family. Think of the surgeon and the recital. And do they have breaks, and do they eat meals during the day? Because we've learned that vigilance is bounded and limited in individuals, and you can use it up. And if you don't take time to recharge, you're much more likely to make mistakes. And then lastly, in the world of engagement, in human resources, folks look at these survey instruments. They're looking at this relationship between the demands of the job and the resources that are brought to the job that then support individuals. So are there growth opportunities, participation in decision-making, the ability to advance in your position and then into other positions? That's you look at against, are people thinking about leaving? Will they be in this position, do they think, within the next year? So these are all measures of culture. And notice that safety culture, the word safety is put into brackets because this is not a measurement of safety culture. These are measures of culture writ large. And when you take culture plus the engagement questions, plus the issues of resilience and burnout, you holistically begin to paint a picture. And you paint a picture that turns out to be quite powerful. Now, let me spend a minute showing you just how powerful. In the United States, CMS, the Center for Medicare and Medicaid Services, pays hospitals based on a star rating. If you get a 4 or 5-star rating, you actually get reimbursed at a higher rate by CMS than if you get a 1, 2, or 3. The CMS star rating is a series of 50 or 60 attributes that are measured in hospitals that include perceptions by patients of their experience, but also include measures of process and outcome, quality outcomes in a variety of procedures that occur in hospitals, orthopedic procedures, treatment of stroke and heart attacks and so forth in emergency rooms. And all of that is packaged together into this rating. And the hospitals in the United States are then arrayed across the 5-star rating and given a grade. We were able, and are in preparation right now to publish it, to look at about 50 hospitals where we could look at in detail culture survey data and also look at their star ratings. And this box and whisker plots show an interesting story. You see the star ratings on the x-axis going from 1 to 5. And you can see in each of these big boxes that we're either looking at work-life balance. I get breaks. I go home at a reasonable hour. I do eat my lunch every day. Teamwork. There are many attributes to the teamwork domain. We coordinate effectively as groups of people, as disciplines. We communicate effectively in and across work settings. I don't have to deal with difficult colleagues. All teamwork questions. Personal burnout. I feel frustrated, exhausted, I feel burnt out. And then burnout climate, the other people around me look frustrated, exhausted, burnt out. When you look at the box and whisker plots, if you just look at the direction of the boxes going up or down, you'll see that work-life balance looks and feels better in the 5- and 4-star hospitals than in the 2- and 3-star hospitals. The same thing is true with perceptions of teamwork. As you look at the 4- and 5-star hospitals, their ratings, the perception of teamwork by the individuals in those hospitals is better than the perception of teamwork in the 2- and 3-star hospitals. Same thing as we go back to work-life balance here. If you look at perceptions of burnout are lower in the 4 and 5-star hospitals than they are in the 2 and 3-star hospitals. And if you ask, when I look at my compatriots, do they seem to be burnout? You can see that the burnout is lower in the 4 and 5-star hospitals than it is in the 2 and 3-star hospitals. In the United States, the star rating has an impact on your reimbursement. So what we are looking at here all of a sudden is measures of culture that can predict where a hospital is going to land on the star rating and have an impact on its reimbursement. And by the way, that star rating is linked to patient perceptions and clinical processes and outcomes. So in essence, what I'm showing you here is a direct relationship between the measurement of culture and the outcome and the finances of an institution. And we can look at these and identify excellence versus mediocrity and potentially even predict what a hospital would be or where it would land in the star rating without even looking at the rating itself. So let's talk a little bit about some of the actions that organizations can do that we know make a difference. We know that the engagement of senior leadership in rounding processes with the front line make a tremendous difference in perceptions and attitudes of people at the front line. And I'll remind you that we've already identified in the previous slide that those perceptions, those attitudes that people have, can be linked to process measures, patient experience measures, and outcome measures, just based on that one slide alone, but we've got others that show equivalently the impact or the relationship between culture and outcome. In this particular case, which we published in 2018 in the British Medical Journal, what we looked at here was a whole group of hospitals in the state of Michigan, where we asked them, almost 30 hospitals, as I remember, where we asked people in the surveys, do you participate in a rounding process with your senior leadership? Number one. Number two, if you do participate in a rounding process, do you get feedback after that conversation has occurred? Now, if you look along the bottom, you can see learning, leadership, teamwork, safety, burnout, personal burnout, and work-life balance. Domains of culture that are looking at different aspects of the culture. The blue has around 17,000 respondents and is the average response of all 17,000 people to each of these groupings of questions that pertain to self-reflection, leadership, teamwork, safety, burnout, and work-life balance. What gets interesting is the green and the red, because these two groups of approximately 4,000 to 5,000 people both answered questions affirmatively when asked, do you participate in a rounding process with your senior leaders? They both said yes. Where the difference becomes is when you ask, did you get feedback after the conversation? And what happens in that particular case is you get the difference between the green scores, which are those individuals saying, I participated in a rounding process and got feedback, and the red scores, those individuals saying, I participated in a rounding process with leaders and my conversation fell into a black hole. Nothing ever came back to me. Now, if you reflect on this for a little while, there are a couple of points that are fascinating. Simply having a conversation, having a sense that I now have voice or agency, meaning my voice counts to influence my environment, makes people feel better across the board about learning, leadership, teamwork, safety, burnout, and work-life balance. On the other hand, if I feel like I'm powerless, I have a conversation, I talk about something that's important, and I'm not listened to, I actually feel worse about the culture in whole. Now, so to some extent, one of the lessons for leaders is, if you're going to round and not give people feedback, don't go at all, because you're going to make the culture worse than just the ambient culture in blue. Whereas if you round effectively, then what will happen is you'll actually improve culture in whole. The conversation alone with leadership, in the sense that I have some control over my environment, improves perceptions of personal burnout, how frustrated and exhausted I am, and improves how you see others. Now, when we published this study with Brian, he then repeated some of the work at Duke in North Carolina, which shows similar kind of results, but adds actually another set of dimensions to them. And let me show you why. Once again, we're looking at domains: learning, leadership, teamwork, safety, burnout, work-life balance. In blue, once again, you see the groups did walk arounds and got feedback. The gray, they did not. And the world just looks better. Less burnout, more teamwork, more learning, etc. for those individuals who feel that they participated in a rounding process that we called classic rounds, because in classic rounds, we're asking about the pebbles in your shoes and the problems. Now, so this looks similar and repeated now to the Michigan data. If we look at another group of people who participated in what we call positive rounding, so somehow or another there's been this distinction of when leaders go in round, should they ask what are the problems, or should they ask who should we identify who's doing good work? And it turns out that when you do positive rounding and look for the good things that are happening, you still have the same impact on the individuals who participate in the rounding process. Ultimately, that conversation about what's going well will lead to what are the kinds of things we might act on. And if the sense that is that, oh, people are going to act on those and I get feedback about it, it makes people feel substantially better about the culture in whole. Interestingly enough, if you do ethics rounds, now Schwartz rounds are not formal rounding where leaders are going down to units, but you're bringing groups together in what is essentially a type of forum. You could call it an ethics forum or a safety forum, where you're discussing issues relating to moral distress or just culture. You know, I feel like I'm forced to do things that I don't want to do or that I don't think are good for a patient, but I don't have the choice. I feel that people were held to account in ways that were unfair. But simply by participating in those conversations, by an organization taking the time to look at those difficult kinds of issues, people feel better when they participate in those than if you don't. And so overall, learning, leadership, teamwork, safety all improve in those individuals who participate than those who don't. Probably one of the most stunning differences is in this one: the organizational response to second victims. So let's think about who second victims are. Adverse event occurs, a patient gets hurt. The clinicians who participated in caring for that patient when the patient got hurt are the ones we describe as second victims. In the vast majority of cases, these are individuals who came in to do good work that day, who are invested in taking care of patients and were involved in some kind of event where patients got hurt. And they may turn out to be accountable, but a lot of the time it turns out the system didn't function the way it should have, and there are system attributes that you want to improve. That's the vast majority of the time. And in situations like that, it's the responsibility of organizations to create and make manifest just culture activities that ensure that when individuals walk away from that experience, they go, I was held to account for my actions, but I was not held to account for things beyond my control or that are flaws in the system. And then probably even more importantly than that group is that everyone surrounding them, in other words, the entire organization, have to look at what happened to these individuals and go, those people, the second victims, were treated appropriately. Now, if some of them are guilty of misbehavior, malfeasance, or whatever, being treated appropriately would be treating them for malfeasance. But if these are events that occur secondary to system complexity, system accidents, pressures on people from the system that are not appropriate, being pushed too hard to work, setting people up to make drug errors by changing drugs based on the price, but the colors of the vials change so that you're being set up to make those kinds of errors. You're accountable for picking the right drug. The system is accountable for putting drugs into a place where you're likely to pull them out correctly. So you have to balance this issue of accountability, and it's not always simple, but there has to be a perception of it that it's fair. When it's perceived as fair, the world looks better to those individuals in blue, when it's perceived as unfair, the world looks really ugly. Those individuals that you see in gray when they answer this question. So just culture turns out to be massively important in the perceptions that individuals have of these aspects of culture. And I will remind you once again that these are staggering numbers. 2 out of 10 versus 7 out of 10 say, yes, there's a learning environment just because just culture is manifest. 2.5 out of 10 versus 6 out of 10 people saying, yes, my leadership support me and give me feedback and so forth. I could go on down this graph, but suffice to say, perceptions of everything look better in an environment that's perceived as being fair and just. And I will remind you from the box and whiskers plot that I showed you earlier, that these differences in perception link directly to how effectively processes unfold and how those processes determine the outcome for patients and the experience that patients have in organizations. This is no longer soft, fuzzy data. This is data that is very real and has an impact on patients, families, and has a massive impact on the carers in organizations. We just published a study looking at a new disruptive behavior scale against issues of teamwork and patient safety. Conclusion, disruptive behavior is a common measurable and associated with safety culture and healthcare worker well-being. You want to look at what we were looking at. Here are some of the questions. Heading in terms of the height of the bars, the percent of staff that report activity in their work setting. Turning your back before a conversation is over, bullying others, publicly humiliating others, hanging up a phone before a conversation is over, making comments with sexual, racist, or ethnic slurs, showing physical aggression. And then we ask, what is the perception of teamwork in these environments? And the answer is that those individuals who report good teamwork see a fraction of these disruptive behaviors as those individuals who see poor teamwork. And it's not as if any of this is, that great a surprise. But when you look at the measurement of it and then think, well, how do we as leaders come in and have conversations with people in a rounding process where you can ask them, what are disruptive behaviors in your unit? Do you see them? Are they an issue? And people can say, yes, I see them, they're an issue, and then find out that they are either dealt with or not dealt with. How are they going to feel about their organization? And then if you go up to the, Schwartz rounds, and in the conversation about an adverse event that happened to an individual and the issues of moral distress about trying to decide who in a COVID environment was going to get the various treatments that were available, but in limited supply. And in the arguments that ensued in those conversations, how were those managed? So you're making visible and discussing in an ethics rounds very complicated but very important issues. And in doing so, people come away with a sense that the organization cares. And because the organization cares, the teamwork functions more effectively. And because it functions more effectively, the care of patients that patients perceive as better and is better measurably. Now we're talking about the linkage between culture and finance and outcomes that's bright and clear and measurable and actionable because we understand the actions that we need to take. And I'll just note here, I put this in because these are some of the questions in the teamwork domain. Disagreements are appropriately resolved in the best interests of patients. I'm able to speak up if I perceive a problem with care. The people here from different disciplines work together in a coordinated way. I don't have to deal with difficult colleagues. Communication breakdowns occur in my unit or across my unit. Negatively worded, but the bottom line is you want this blue circle to be all the way in the green out at the 80 to 90 percentile. And some of these numbers in this particular unit were staggeringly bad, but our national percentages are only sitting in the 40 percentile here. 4 out of 10 people saying communication is good in and across my units. 4 out of 10 people saying I don't have to deal with difficult colleagues as consistent part of my job. 6 out of 10 are saying, these are national averages, in our surveys of hundreds of thousands of people, people are saying, yes, I do have to do these. But what's interesting is that we can make correlations. We understand that every time we do better overall in these teamwork scores, we're likely to see a 6-point increase in the improvement readiness domain. All of these groupings of culture are tiled and related to each other, so that as you improve one, you often get the benefit of another. And when you improve both of them, they have a synergy to them and become even better. And ultimately, you get to this tipping point where you're then in a position to begin to move towards the ideal. And here's the ideal, right? Where culture, knowledge, and learning systems are effectively managed by leaders who understand the skills, activities, and behaviors that they have to learn about, participate in, and where they have to manifest particular kinds of the behaviors, curiosity, humility, respect, and so forth, during the time that they're in those activities. So in summary, in 2021, we know what to do to create healthy cultures. We can measure the cultural activity. We can measure the changes that occur, rounds and briefings, and the impact that they have. And finally, these activities that we're talking about are not rocket science. They do have to be meshed together holistically. They do require some coaching in order to be robust. And the measurement of them has to be visible and transparent to all. So you have to make the measure. Do the group of people in the ICU after rounds know the game plan that day? And are they able to enact that game plan as the day unfolds? When they debrief at the end of the day, do they all say, yep, the game plan we all had in mind was one and the same, or no, we didn't communicate as clearly as we should have? Those are measures that you can collect and put up on a screen and work against to continuously improve. So a very brief primer on culture and its impact on clinical process and outcome. Delighted to have had this opportunity to talk to all of you, and thank you so much for listening.